Imagine you're having open heart surgery. The surgeon is standing over you and casually takes a drag of his cigarette. Nobody bats an eye. In 1960, that's just normal. The anesthesiologist beside him isn't watching a monitor. There are no monitors. He's watching the color of your skin. If it turns blue, something went wrong. If not, you're still alive for now. You'll wake up after the operation in a shared ward with 7 other patients. Painkillers are scarce. Antibiotics are rationed. And your chances of dying right there on the table are roughly 20 times higher than they are today. Welcome to the operating room of 1960. Today we're comparing everything: anesthesia, instruments, survival rates, and the people who stood on the other side of the scalpel. By the end of this video, you'll understand that medicine has traveled a distance of several human lifetimes, and did it in 60 years. Anesthesia. In 1960, the most common general anesthetic was ether, diethyl ether, a drug that had been around since the 19th century. The patient was laid on the table, a mask placed over the face, sometimes just a piece of gauze, and ether was dripped onto it. The person lost consciousness. The surgeon got to work. That sounds primitive, but it gets worse. Ether is flammable. Operating rooms in the 1950s and 60s used electrical equipment, instruments that could spark open-flow oxygen. Explosions in operating rooms weren't science fiction. They happened. Cases where the anesthetic ignited mid-procedure are documented in the medical literature of the time. Controlling the depth of anesthesia was nearly intuitive. Anesthesiology as a profession was still taking shape. In many hospitals, anesthesia was administered by a nurse or even a junior surgeon. No specialized training was required. There was no pulse oximeter, the device that tracks blood oxygen saturation. No capnograph to monitor carbon dioxide levels. No automated blood pressure control. The anesthesiologist worked by observation: breathing, skin color, pupil response. The pulse oximeter, which today is in every operating room and costs about $30 at the pharmacy, wasn't invented until 1972. It didn't enter widespread clinical practice until the 1980s. Before that, people died from anesthesia far more often, and the cause often remained unknown. The patient simply didn't wake up. The surgical log would read, "Cardiac arrest." There was a separate nightmare known as intraoperative awareness. That's when a patient under anesthesia regains consciousness during the procedure but cannot move or signal for help because the muscle relaxants are still working. They hear everything. Sometimes they feel pain, and there is nothing they can do. And the era of primitive anesthesia monitoring, this happened far more often. We don't know the exact statistics from that time. Patients didn't always understand what had happened, and even when they didn't always speak up. Today, specialized anesthesia depth monitors, such as the BIS monitor, track brain activity in real time and allow the anesthesiologist to keep the patient in precisely the right state. Today, anesthesia is an exact science. Short-acting drugs that the anesthesiologist adjusts in real time. Dozens of sensors continuously monitoring every function of the body. A specialization that takes 8 to 10 years to complete. Mortality directly from anesthesia in the 1960s was approximately 1 in every 1,500 operations. Today, it's around 1 in 250,000. That's a 170-fold improvement. The operating room. Walk into an operating room in 1960, and the first thing that would hit you is the smell, ether, sometimes cigarette smoke. Operating rooms were not strict no-smoking zones. Surgeons often smoked before a procedure and sometimes stepped out for a break during long operations. Sterility was a concept that existed, but was understood differently. Yes, hands were washed. Yes, instruments were sterilized in autoclaves with steam. But the idea of a clean zone and a contaminated zone was far less defined than it is today. A surgeon could walk out of the operating room, speak to a patient's family, walk back in and continue. Gloves were worn, but not always double-gloved. Masks were used, but not always worn correctly. Ventilation in operating rooms was far inferior to modern standards. Laminar airflow systems, which are standard today, didn't appear in most hospitals until the 1970s. Lighting is its own story. Operating lamps in the 1960s were functional but cast shadows. Surgeons worked with headlamps, assistants held additional light sources by hand. In cavity procedures, abdominal, thoracic, visibility was limited by the depth of the surgical field and the physical fatigue of the assistant's arms. X-rays were the only way to look inside before an operation. Ultrasound as a diagnostic tool emerged in the late 1950s, but entered clinical practice slowly. MRI wasn't invented until 1977. The CT scanner came in 1972. That meant the surgeon often learned the true condition of a patient's internal organs only after opening them up. Surgical planning was built on assumptions. There was another problem: temperature. Operating rooms in the 1960s didn't always maintain the right climate. A patient becoming hypothermic on the table raised the risk of cardiac arrhythmia, slowed blood clotting, and extended recovery time. Warming systems for the operating table and the patient didn't become standard until the 1980s and 90s. Today, a surgeon walks into the operating room already knowing a three-dimensional model of what they're about to see: CT, MRI, PET scanning, intraoperative ultrasound. They've already flown through the patient's internal organs in digital space the day before. During the operation, open a surgical textbook from 1960, and you'll find techniques that look crude by today's standards. Incisions were large, not because surgeons were careless, but because there was no other way. Without endoscopes, without laparoscopy, without robotic systems, the only way to reach the right place was to open wide access. A stomach operation might require an incision of 20 to 25 centimeters. The consequences: long recovery, high risk of infection, significant blood loss. Blood transfusion existed as a procedure by 1960, but carried far greater risks than today. Testing blood for infections, HIV, hepatitis, only became possible in the 1980s when those viruses were identified. Before that, a transfusion could save a life and simultaneously infect someone with a fatal disease that nobody yet knew existed. Intraoperative monitoring, as already mentioned, was based on direct observation. The electrocardiograph existed, but it was a bulky device never designed for the operating room. Continuous ECG monitoring during surgical procedures only became standard gradually through the 1960s and 70s. Surgical instruments were metal, reliable, reusable. That sounds sensible until you learn that sterilization in overburdened hospitals sometimes failed. Infection from an improperly processed instrument was not uncommon in that era. Today, laparoscopic surgery, 3 half-centimeter punctures, has replaced large incisions for most routine operations. The patient goes home the next day. In 1960, after gallbladder removal, a person spent a minimum of a week in the hospital. The Da Vinci robotic system, which entered widespread practice in the 2000s, allows a surgeon to control instruments with sub-millimeter precision, with tremor filtering. Literally, the computer removes the natural hand tremor that every human being has. The surgeon sits at a console several meters from the patient and operates with a level of precision that is physically impossible with bare hands. After the operation, imagine you've been sutured. The anesthesia is wearing off. Where do they take you? In 1960, most likely a general ward. 6, 8, sometimes 12 beds. Specialized intensive care units barely existed. The first I See Us began appearing in the United States in the late 1950s, but by 1960 they were rare. Post-operative pain relief was minimal by the standards of that era. Opioids were used on morphine, meperidine, but cautiously out of fear of addiction and side effects. The patient endured. Antibiotics already existed. Penicillin was discovered in 1928, widely used from the 1940s. But the range of available drugs was narrow, and post-operative infections remained a serious threat. Sepsis after surgery killed people who had survived the operation itself. Physical therapy and early rehabilitation. That is, the idea that patients should get back on their feet and start moving as soon as possible came later. In the 1960s, bed rest was the standard of care for several weeks. This alone led to fatal outcomes: venous thrombosis and pneumonia due to prolonged immobility. Nutrition was its own issue. For a long time, surgeons followed the rule of nothing by mouth for as long as possible after an operation, out of fear of burdening the gastrointestinal tract. Patients lay on drips, losing muscle mass, growing weaker. Today's protocols call for feeding patients within a few hours after a minor operation because nutrition accelerates healing and immune recovery. Today, a patient after laparoscopic cholecystectomy goes home within 24 hours. After a minor knee procedure, within hours. Enhanced recovery after surgery protocols, ERAS, were developed in the 1990s and 2000s and are now standard worldwide. Post-operative mortality for elective surgery has dropped so dramatically that today we treat it as nearly zero, even though the risk is always there. The surgeons, the people behind the scalpel. In 1960, the surgeon was a god. Not metaphorically, literally in the cultural sense. The authority of the chief surgeon in the operating room was absolute. No one asked questions. Nurses stayed silent even when they saw an error. The resident didn't dare interrupt. The same phenomenon we discussed in the aviation video, the authority gradient, when a junior team member spots a problem but doesn't dare say so. In aviation, it was called the cockpit authority gradient. In surgery, the same thing existed. It just didn't have a name. Research showed that a significant portion of deaths on the operating table in the 1960s and 70s were linked not to technical errors but to communication. Or more precisely, the lack of it. Beyond that, surgeons didn't keep records the way they do today. Surgical documentation was inconsistent. Complications weren't always logged. A patient dying on the table was a tragedy, but not necessarily grounds for a formal review. Auditing surgical outcomes, the systematic analysis of who dies and why, only began to be implemented in the 1970s and 80s. Before that, a hospital could lose patients to the same cause for years and never know it. In 2008, the World Health Organization introduced the Surgical Safety Checklist, a list of 19 items that the team is required to go through before every operation. Basic things. Does everyone know the patient's name? Is it the correct side of the body? Any allergies? It sounds obvious. But a study published in the New England Journal of Medicine in 2009 showed that implementing this checklist reduced mortality by 47% and complications by 36% across 8 hospitals around the world. 47% from a list on a piece of paper. It tells you how many deaths used to happen not because of technical complexity, but because of simple, preventable errors. The operating room of 1960 was a place where less depended on you than on luck, where one person's skill decided everything, and where no one had the right to correct that person. If you enjoyed this video, subscribe. Thank you, and see you next time.